And then just getting back to it, this training, along with our trainings entitled ethics, ethics and data collection and ethics across the SBF, can be completed to satisfy the 6 hours of ethics training required to become a certified prevention specialist. Moving on. Now, to review the agenda for today, in the remaining time we have together, we will review the following: some background information on the Prevention Professional Code of Ethics and an ethical decision-making process. Then we'll take a closer look at the ethical principles for prevention professionals. We'll talk about non-discrimination, competency, integrity, nature of services, confidentiality, and number 6, the ethical obligations to community and society. Then during a short break, we will offer an opportunity to take a brief knowledge acquisition test or a learning checkpoint test. We will come back and we'll do an activity during which we will put you all into small groups, and y'all will have a chance to react to some ethical dilemmas and apply the ethical principles we have covered.
Maybe we'll go this afternoon if we have to.
Okay. And so here we are. This is module 1 of 3, where we will provide an ethical foundation for prevention professionals. So starting with why ethics. Ethical codes exist to guide professionals to ensure fair and optimal practice.
Give me a second.
David, if you want to scroll over my name really quickly, sorry to interrupt you, and make me a co-host, I can handle the muting.
Okay, thank you.
Sorry.
No, it's fine. Thank you, Jen. All right, so getting back into it, apologies. So why ethics? Ethical codes exist to guide professionals to ensure fair and optimal practice. The grounding expectations for professionals across industries and sectors in our society are membership in an occupational organization, special expertise, service orientation, and autonomy. And autonomy meaning the capacity to decide for oneself and pursue a course of action regardless of moral or ethical content. Then now to further discuss some of the standards of the profession in the field of public well-being or health, prevention professionals should meet the grounding expectations that I previously mentioned, which are the membership to occupational organization, special expertise, and service orientation, and then autonomy, and that professionals will not place personal gain ahead of public good. As a result of these expectations, society grants professional standing to prevention practitioners because they seek to promote the well-being of the broader society. The purpose in reviewing these standards is to underscore the moral obligation within the prevention profession, which is service to humanity. As prevention professionals, we also have several layered obligations to the organizations that we are employed by, as we may have different workplace policies depending on the organization or agency that we work for, to the greater public, and to the integrity of the practice. These obligations will factor into your decision-making process when posed with an ethical dilemma. So, every profession has a moral purpose. Law has justice, public relations has harmony or social harmony, and prevention has public health. The moral purpose of prevention professionals is derived from their contribution to society, which is promotion and maintenance of public health. It is this professional responsibility for prevention practitioners that highlights their ethical obligation in various what their ethical obligation is in various situations. For example, it is reasonable and appropriate to expect prevention practitioners to make decisions based on their ethical obligation to promote public health. They prioritize public health. Therefore, it is reasonable and appropriate to have different expectations of people in different fields like business, engineering, tech, and particular concentrations within the field of law. These differences in expectations exist because folks in different industries have unique goals, standards, and purposes, and agendas. It is important to be mindful of the different objectives and agendas across industries because in the field of prevention, you'll likely be working to organize and mobilize representatives of various sectors, and you want to come together with those agendas. So understanding ethics as a decision-making process. We'll briefly discuss the difference between the terms morality and ethics. Most people use the term morality and ethics interchangeably, yet for the purpose of this presentation, morality refers to the actual content of right and wrong. The differentiation is derived from cultural, societal, or communal interpretations, and the understandings of what is right and wrong. That these understandings of right and wrong are absorbed by an individual through a sort of subtle or overt teaching. Ethics refers to the process of determining right and wrong, and ethics, as we apply them in this presentation and to the profession, mean a system or a code of morals that guide a profession. So the Prevention Think Tank Code of Ethical Conduct. It was created by the Substance Abuse and Mental Health Services Administration, Prevention Think Tank, or the SAMHSA Prevention Think Tank, and the International Credentialing and Reciprocity Consortium, or IC and RC. The IC and RC promotes quality work and maintains the integrity of the addiction and prevention professions by setting standards and developing exams for credentialing professionals. The Prevention Think Tank Code of Ethical Conduct is guided by core prevention values and competencies, provides models of exemplary behavior, recognizes our responsibilities to the field, and promotes trust from society and those that we serve. Before reviewing the 6 ethical principles defined in the Code of Ethical Conduct, I'll describe and review the DECIDE decision-making model. So this is the DECIDE ethical decision-making model. It lays out a memorable and easy to follow protocol for making ethical decisions upon encountering an ethical dilemma. And a graphic laying this out will be provided to you at the end of the presentation. So going through the DECIDE model. The D stands for define the decision that needs to be made. And while you're defining the decision that needs to be made or defining the problem, you ensure that the decision or dilemma is clear and specific. E stands for entertain all possible options or possible solutions. As you're doing this, be mindful that there are often multiple solutions. C stands for compare each option and its associated consequences. I is identify the best decision, select the option that leads to the best outcome for everyone involved. D is design and implement an action to create an implementation plan. E is evaluate the results, and some questions to keep in mind while you're evaluating those results are, did the anticipated consequences happen? Would you take the same course of action or make a different decision? And then I'd also like to offer 2 additional considerations. When applying this model, you should ask yourself what ethical principle is relevant to the situation and which sectors of the community are or may be involved in the situation as far as the solution or the problem to begin with. So now we'll get to the Prevention Code of Ethics. Before getting to the 6 ethical principles, I wanted to share and review the preamble of the Prevention Code of Ethical Conduct. It affirms some of what I've already described, and I highlighted some stuff in red, but I'll give you guys like 15, 20 seconds to briefly scan over it.
If I can jump in just for a moment, David,
Absolutely.
anybody who's applying for certification will be asked to sign the Prevention Code of Ethics at the time of the test. When you pass the test, they ask you to sign this at the Connecticut Certification Board as part of the earning your certification. And for many of us, that's the only time we sign a document. Sometimes you sign one like when you're being hired or going through orientation, but most of us don't go through that. So it's good to know these ethics, not only to guide our work, but they're also a topic for the exam, and then we'll have to sign a document as well.
Thank you, Lisa. So I highlighted in red here the prevention profession's obligation to promote the well-being of the public, including individual practitioners' responsibility to help and hold their colleagues accountable. And those are things that we'll actually get into deeper later on in the presentation. And then I also highlighted that you should, as a prevention professional, you should put your professional duties and responsibilities before your personal views. Now that we have a foundation, like a basic foundation upon which to stand, let's review the ethical principles more closely. As they appear in the code, they are number 1, non-discrimination, number 2, competence, number 3, integrity, number 4, nature of services, number 5, confidentiality, number 6, ethical obligations for community and society. And we'll begin with non-discrimination. So prevention professionals should not discriminate. This is the definition. This is that exists within the the Code of Ethical Conduct. Prevention professionals should not discriminate against the service recipients or colleagues based on their demographic identity, including but not limited to race, national origin, gender identity, age, sexual orientation, education level, economic or medical condition, physical, mental ability, marital status, or political. Going further into this principle, the principle as it is outlined in the code also describes practices to help practitioners avoid discriminating folks. The Code of Ethics recommends that prevention professionals broaden their understanding and acceptance of cultural and individual differences to provide services and resources that are sensitive to those differences. Prevention specialists shall comply with or should comply with all local, state, and federal laws regarding the accommodation of individuals and with disabilities, and also regulations involving non-discrimination of other protected groups. So some of the key points within this principle are preventing and avoiding discrimination, complying with anti-discrimination laws and regulations, and promoting cultural competency in the prevention profession. So for key point 1, it's avoiding and preventing discrimination. And it is important that you not only know, as a prevention professional or a prevention practitioner, that you not only know what discrimination entails, but also that the folks you work with are also well informed on this too. And that you know how to navigate a scenario when discrimination is occurring. Sorry. You should be mindful that discrimination and or prejudice may affect any demographic group. In your practice, you should actively assess circumstances for any potentially discriminatory or prejudicial implications. For example, let's say you produce an awareness raising content that is offered in English, Spanish, and Portuguese. At first, this certainly seems like an inclusive content dissemination strategy, but after further investigation, you come to realize something new or something you didn't know about languages spoken throughout your community. In addition to the substantial Spanish and Portuguese populations, there also exists a large population of parents who mostly speak Bengali and Korean languages. Although unintentional and not overtly harmful, a subset of the population was unreached by the content strategy. And this is all to say that our recommendation is to be proactive about who you may or may not be, who you may not be considering in your prevention practice. Key point 2, prevention practitioners must comply with anti-discrimination laws and regulations. The non-discrimination law refers to legislation designed to prevent discrimination against certain subsets of people. These subsets are commonly referred to as protected groups or classes. Non-discrimination laws vary by jurisdiction regarding the types of discrimination that are prohibited, and also the groups that are protected by that legislation. Some of the laws that I wanted to mention are the First Amendment, which is freedom of religion for all persons, the 14th Amendment, which grants equal protection under the law for all persons, and then the 15th Amendment, sorry about that, prohibits against denying voting rights on the basis of race and color. And then there are several other amendments, like there are educational amendments, the Civil Rights Act of 1964, and guaranteed some or prohibited some exclusion of based on race and national origin. And then there are some Connecticut specific regulations and rules that protect people. And there we'll be providing a link to some of the laws, the relevant and anti-discrimination laws at the end of the meeting. So there are federal anti-discrimination laws outlawing discrimination on the basis of the following: race, religion, national origin, age, sex, pregnancy, familial, marital status, disability, and veteran status. In addition to the 9 federally protected classes and groups, the Prevention Code of Ethics identifies 4 more bases on which to prevent discrimination. Sorry about that. These are economic condition, gender identity, political beliefs, and HIV and AIDS status. Since the prevention profession is a social service profession, it is necessary to provide a wide range of easily accessible services to the community. It is crucial that accommodations be made to ensure that every member of your target community can access services without incurring an unreasonable burden. It is also imperative for prevention professionals to stay up to date on their state's laws concerning anti-discrimination. And again, a link will be provided that lists the anti-discrimination laws that affects Connecticut residents. Key point number 3 is to promote cultural competency. Apologies. And then promoting cultural competency. In promoting cultural competency, it is not only important to inform yourself on the fundamentals of race, ethnicity, gender identity, sexual orientation, and several other demographic identifiers. It is also important to inform yourself on the cultures of distinct working groups, like the military, academic communities, or public servants. They are all unique. Each group may have distinctive cultural characteristics that you will slowly familiarize yourself with while you're collaborating with them. And the reason I mention this is, as you inform yourself of these cultures and characteristics of distinct groups, you should also seek to learn about the potential traumas of those traumas and triggers of those groups to prevent harming them, from unintentionally harming them. It is also critical to reflect on your own biases so as to avoid subtly or unintentionally discriminating against the folks that you work with. So the next principle we'll cover that is in the Code of Ethical Conduct is competence. Principle number 2. In short, the principle of competence prescribes prevention practitioners to gain mastery in their subject area and recognize the gaps in their knowledge. So the definition as it's laid out in the code is that prevention practitioners should strive for constant learning in their field to refine the services that they provide to the people they serve. Competence is a blend of education and practice. It demands an understanding of the theory, rationale, and awareness that guides your practice, and the hands-on skills that are only learned through implementing and troubleshooting actual practice strategies. The 4 pillars of competency are as follows. Number 1, prevention practitioners shall discharge responsibilities thoughtfully. This requires practitioners to provide services promptly and strategically while adhering to technical and ethical standards. Number 2, practitioners should take due care of their professional responsibilities. This requires developing a plan, monitoring the implementation of the plan, and evaluating the success of the plan and its implementation. Number 3, practitioners should recognize their own limitations and boundaries in their knowledge and encourage others to maintain that same standard. When asked to perform services outside the scope of their expertise, practitioners should defer to an appropriately qualified professional. Number 4, practitioners should passively assess practices employed by their colleagues and affiliated organizations for unethical conduct. They should report the conduct to the appropriate regulatory bodies. So as far as the key points to this principle, it's assessing your own qualifications, planning, executing, and evaluating professional activity, recognizing the limitations and boundaries in professional competencies or services, reporting unethical conduct. So key point 1, assessing your qualifications. You must be diligent and meticulous in your practice. And to determine if you are qualified to provide an efficient and effective practice, some of the key questions you might ask yourself are: do the actions that the activity require align with your job description? Are you familiar with the particular population and setting you intend to work with? Do you have familiarity with the culture of the broader community that you are targeting with your strategy? And do you have relevant training and experience to effectively employ the hypothetical activity? Altogether, sorry, the takeaway message here is to be honest and courageous about the skills you have and do not have. Key point number 2 is planning, executing, and evaluating professional activity. Then we move on to effective planning and evidence-based interventions. While employing your prevention strategy, it is crucial that practitioners are thoughtful and strategic with their actions. The information and resources that you use should be dynamic, data-driven, inclusive, and stoke collaboration among the service community. To ensure effective service delivery, first and foremost, you should adhere to the contract and grant instructions. Additionally, when sharing awareness-raising resources or prevention resources, you should source your materials from nationally recognized registries of effective programs, peer-reviewed journals, credentialed evaluators, and/or experts in or of your focus population. Then key point 3 is very similar to determining your qualifications, and it is recognizing your limitations and boundaries in the professional competence and services that you may provide. Key point 4 is reporting unethical conduct. With this point, it is important to inform others of the harms caused by unethical conduct and thereafter to report suspected displays of unethical behavior among colleagues and affiliated agencies. These behaviors as they relate to the competence can include acting outside of the scope of practice of the individual's credentials or gross negligence while providing service to the community. For example, spreading misinformation, whether intentional or not, is an inappropriate interaction with your service population. We recommend to investigate who in your organization or workplace you would report unethical conduct to. And if there is someone, and also if they are someone you can talk to when you're confronted with an ethical dilemma. Ethical principle number 3 is integrity. So what does it mean to have integrity? The definition the working definition that we'll use today is to be honest and show a consistent and uncompromising adherence to strong moral and ethical principles and values. How does it relate to the prevention workforce? Integrity is standing for something. It is adherence to a moral purpose, and it is maintenance of the prevention workforce. The Prevention Code of Ethics frames the ethical principle as follows. To maintain and broaden public confidence, prevention specialists should perform all responsibilities with the highest sense of integrity. Personal gain and advantage should not subordinate service and the public trust. Integrity can accommodate the inadvertent error and the honest difference of opinion. It cannot accommodate deceit or subordination of principle. So the code goes on to state the following to maintain integrity. All information should be presented fairly and accurately. Each prevention specialist should document and assign credit to all contributing sources used in published material or public statements. Prevention specialists should not misrepresent either directly or by implication professional qualifications or affiliations. Where there is evidence of impairment in a colleague or a service recipient, a prevention specialist should be supportive of assistance or treatment. Prevention specialist should not be associated directly or indirectly with any service, products, individuals, or organization in a way that is misleading. Some of the key points that we can derive from this principle are the following. Prevention practitioners are expected to provide accurate information, give credit for ideas, information, and materials, support impaired colleagues and service recipients, and avoid deception. And then just to take a deeper dive, in providing accurate information is not always as easy or as intuitive as it seems when presenting data. A few guiding questions you may want to ask yourself when you're disseminating information is, where are you getting this information from? Be sure that your information is coming from a reliable source. And is the information current or is the information outdated? The residents of our communities are looking to us to provide them with accurate and up-to-date information. If we are presenting data in our communities, we want to avoid sources like uncited social media posts or obscure news outlets. Instead, we should collect our data from sources like the CDC, NIDA, National Institute on Drug Abuse, DPH, or DMIS, and several others too. And then, so this is just like, you should avoid saying things that are blatantly misleading. I'll just say use some of your intuition when assessing the legitimacy of a resource. So the key point number 2 is to give credit for ideas and information and materials. The fundamental point while giving credit is to always cite before you write. Some examples when giving credit is necessary, and should be the first step. When creating materials that include information, ideas, or data that are not your own or your organization's, or when using or translating charts, graphs, photos, artwork, or graphics that are not your own. If you're doing either of these, you should prioritize giving credit to these ideas through citations. If you're not citing, then the ideas are being plagiarized. Copyright laws are in place and may be enforced to protect the authors of their original work. Again, this applies to materials that are not your own or your agency's. Although some copyright laws may suggest otherwise, you should cite your source even if you believe you are using the source's materials for educational purposes. Additionally, there are Creative Commons licenses for photos that enable you to use photos, but again, citing is the best is the best thing to do, just to cover yourself. Key point number 3 is that practitioners should support impaired colleagues and service recipients. As prevention professionals, it is our responsibility to provide support to those we are providing services to, and to ensure that they are connected to the appropriate resources when available. Additionally, sometimes we are so engrossed in providing services that our target populations that we may not recognize if and when our coworkers are in need of help or support. In this profession, we cannot look away or shirk responsibilities. We help. As we mature in the field, we familiarize ourselves with resources to offer service recipients, and should share them with our colleagues or our admin at their request if we notice irregularities in their behavior. To adhere to this principle, you should familiarize yourself with your organization's policy regarding workplace impairment. This includes some of these policies can include facilitating employees to getting treatment, providing reasonable suspicion training, and then the purpose of these trainings is to teach supervisors to identify circumstances that may create reasonable suspicion that someone is under the influence of drugs or alcohol. Then drug testing, and then employee access to rehab and treatment programs. So key point number 4 is to avoid deception. Deception involves misleading others or trying to make them believe something that is not true. It diminishes the trust of others and undermines integrity. Integrity cannot accommodate deceit, as we mentioned earlier, and regardless of intention, deception is unacceptable. Often we think of deceit as manipulating information for personal benefit, but sometimes deception can occur in a more covert way, such as withholding information. So then moving on to the ethical principle number 4 for prevention professionals, which is nature of services. The services that we provide should respect an individual's dignity should be based on evidence. They should protect and promote health and well-being to our service population, protect all those affected by the issue and protect all those affected by the issue at hand. The Prevention Specialist Code of Ethical Conduct outlines the principle as follows. Practices shall do no harm to service recipients. They should safeguard the dignity of the population served. Services should be provided in a manner that honors and preserves the protective factors inherent in each culture and individual. Prevention specialists should use formal and informal structures to gather and incorporate feedback or input from the service recipients from beginning to the end of a prevention initiative. Which includes problem identification, strategy development, implementation, and evaluation. Where there is suspicion of abuse of children or vulnerable adults, the prevention specialist shall report the evidence to the appropriate agency and follow up to ensure that the appropriate action has been taken. The key points in this principle are the following: protect participants from harm, involve the focus population in all aspects of a prevention initiative, and report any evidence of abuse. So for key point 1, protecting participants from harm, how can we do this as prevention professionals? We conduct background checks on folks that we hire as service providers, especially if the individuals are working with children or with a youth service bureau. We can also make sure that we obtain informed consent when working or conducting research of any kind with individuals or groups. Informed consent requires you to describe the research activity or in great detail, also in a way that is easily understandable. Additionally, remind program and/or research participants that they are volunteering to participate and giving their consent willingly. The key terms related to protecting participants from harm are the following: informed consent, which is the process of obtaining consent from participants that includes a full description and explanation of the activity, presented in a way that the participants can understand, and ensures that participants provide their consent willingly, free from coercion and undue influence. Active consent requires a signature from all participants in research projects and/or their legal representatives. Passive consent requires a signature from only those individuals who do not agree to participate in the research activity and/or legal representative. Informed consent is needed for all research activities. Many of us work with youth. For example, we usually cannot collect data from minors without parental or guardian permission. Sometimes IRB approval is needed for research activities. If you're unsure, consult with partners who have research expertise. Also, please consider the DMIS Center for Prevention, Evaluation, and Statistics, or CPIS, one of the many Connecticut DMIS prevention resource links, as another resource for when you're conducting research or anything of this sort. Key point number 2 is to involve the focus population in all aspects of the prevention initiative. So why is this component important? This is crucial to the success of any program we are implementing in the community. If we venture back to the SPF for a moment and think about capacity building, this concept of involving the focus population facilitates the process of building capacity with your coalition. The additional benefits of involving the focus population in every step of your prevention initiative are: it provides the community an opportunity to gain a better understanding of health issues and local public health priorities. It mobilizes the community by encouraging residents to provide input on problem identification and strategy development. And it builds trust and credibility within your community. Key point number 3 is to report any evidence of abuse. In addition to this, laws are in place to prevent children from being abused and to end any possible neglect or abuse at the earliest stage. Mandated reporters are legally required to report any suspicion of child abuse or neglect to the relevant authorities. We as prevention professionals have a responsibility to follow up with the appropriate agencies upon witnessing or gathering evidence of abuse to ensure that the proper actions were taken. So now I'll hand it off to Lisa to discuss the next 2 ethical principles.
Thank you, David.
Thank you.
And if you wouldn't mind continuing with the PowerPoint slides, that would be great.
Will do.
Next on our list is confidentiality. So we'll be talking about confidentiality as the 5th principle. And if we could go to the next slide. Okay, confidentiality. What's important here are 3 different terms: privacy, the basic right that all citizens have, confidential information, what we consider ethical, part of our ethical relationship that we have to the people we work with, and privilege. Who has the legal is a legal concept. Who has the right to release confidential information? And confidentiality, as we all know, is not absolute. There are times when we break confidentiality, and that is in terms of abuse or neglect, or if somebody's in danger of hurting themselves or someone else. So those would be the times when we break confidentiality. And if you need to know more about this, it's definitely worth checking out your organizational policy around this as well. But the idea is, what is private information that belongs to the people we're working with versus information we can share? Most of us are not working in a situation where we're going to be privy to lots of confidential information of a person, unless, for example, a young person or parent shares that information with us. We tend to work more with aggregate information about a group, like a student survey. We're not looking at sharing the information on individual students, how they reported. Instead, we're working as aggregate. We're summarizing all that data and talking about the group, but it's still important to know about confidentiality. And this also comes from years past, when many prevention professionals were working in the school, acting as substance abuse professionals, working with kids who may have problems or using substances. So that's where a lot of this comes from. So it's still included in the ethics, and it's still covered under the exam for being a prevention specialist for your credentials, your certification. Okay. So confidential information acquired during service delivery shall be safeguarded from disclosure, including but not limited to verbal disclosure, information that people share with us when they're speaking, unsecured maintenance of records, or recording of an activity or presentation without appropriate releases. So that's one thing we talk about, is when we're recording young people especially, we need to have releases signed. And usually most organizations have policies around that, getting permission if we're going to share photos, for example, or include them on, say, a video recording. Prevention professionals are responsible for knowing the confidentiality regulations relevant to their prevention specialty. So, for example, if I was working in HIV prevention, it may be different from substance abuse prevention. So those are some of the things we need to know. Okay. Okay, and then we're going to go over 3 quick items. One is verbal disclosure. The second will be security of records. And the third will be recording activities. So we'll go to verbal disclosure. And what's important here is when people are sharing information about themselves, verbal disclosure refers to interpersonal, what people share with us, expression of self-relevant information about myself. And that includes, what I reveal about myself, my attitudes, my thoughts, my behaviors. We cannot disclose the identity of anyone receiving substance abuse services. For example, if we were, I'm going to give an example that occurs in my high school. At the high school where I live here in Southington, we have a vaping education program for kids who have violated the vaping policy at the high school. And the person who is conducting that, who is our coalition coordinator, cannot reveal the identity of those kids to anybody in the coalition, to any educators, to any other students or other parents, because that would be considered a substance abuse program. She can share information like with the administrators who have referred the kids and who may need to know, have they completed the series? But she really technically shouldn't be sharing, information about where are they on the progression of use. So it's important to know exactly what kinds of information you can share with who, but people receiving substance abuse services, whether they're in a formal treatment or treatment program or not, we are not to disclose their identity to people. Okay, next slide. Security of records. And this is, we need to keep records secure in a locked cabinet. And this is records, again, that not like minutes from meetings, but this would be more records that are identifying personal, private information of individuals. That would need to be, and especially if, say, you're seeing someone and providing support to them and keeping records on that, those would need to be in a secure place. And it gets more complicated now when we do so much technology. Like, for example, if you're taking intake records on someone, you would need to keep those secure. With technology, we need passwords, we need encryption programs to protect it. If we're networked, we need firewall and virus protection to prevent somebody from getting into those who aren't authorized. And if we're using things like Basecamp or Dropbox, that's important. Those are, or Google Docs, those are more easily accessible to folks outside the group you may be working with. So those are some things to keep in mind. And again, we're talking about, individual records of folks. And when we're talking about survey data and survey reports, again, we're talking about when we're releasing information, it's the aggregate of everyone who participated. So we're not looking at individual surveys. The one exception might be if you're looking how individuals have changed over time and you're assigning them personal IDs like random numbers, you would need, and then you're going to use the same random number for them later, say 2 or 3 years down the road to compare differences. That would have to have certain confidential protections. So somebody doesn't identify who that survey belongs to. And that's where the random number would be kept for that individual. And then a list of who has those random numbers, what the random number is assigned to, who the person is assigned to would be kept separate from that. Okay, next slide. Recording activities. And what is important here is that, assuming reasonable expectations of privacy, getting releases signed, making sure people understand how the materials might be used, that no confidential information is shared. So that's one of the reasons sometimes trainings may not be trainings that we do may not be posted on our YouTube channel, because sometimes we are getting into the weeds and talking about issues that communities may be facing. And rather than share that information online, we decide not to post that information. One example would be when we're doing a learning community with specific coalitions. We won't post that online for anyone to view. The same can be said for, if we're interviewing, if a student happens to share some private confidential information, we may edit that out of a video. We should, rather than identifying that. So, and we need to keep in mind, when we're creating promotional materials as well about a program, do we have permission to use that person's photo? Has a release been formed? If, for example, we are promoting a program for kids who may have substance abuse issues, we technically shouldn't be posting their picture in that, because that would be identifying them as a client or a program participant. We need to protect people's identity. We need to make sure no confidential information is shared, and we need to be consistent with our organizational policies as well. And what I recommend is, if you're new to this, connect with us, connect with CPIS, the Center for Prevention, Evaluation, and Statistics, Jen Sussman, and connect with other trusted professionals, prevention professionals who have done these types of activities as well. Okay. Workplace policies to consider. Some of the things we need to keep in mind is training all administrative and support staff about confidentiality and providing them with appropriate oversight or supervision to ensure compliance. For example, in our organization, we discuss once a year what our workplace policy is around confidential information. We go through a mini training on that, and we all sign a form that we will adhere to it, and that if we have questions, we will check in with people who are designated to do that. So making sure there's some kind of an orientation or training or conversation to make sure folks are aware of that. Ensuring that all records are secured in a secure location, and only people with access to those records have a legitimate need to access them. The only people who should be doing it have a legitimate need for them. Never discussing clients in a public forum or with individuals not authorized by the client to have access to the confidential information. Okay. Using technology with an understanding of the possible risks to confidentiality. Each type of technology may bring with its use. For example, there's differences between emails, computers, fax machines, et cetera, and how they can be hacked or unauthorized use of that. So it's important to minimize the risk of inadvertent release of confidential information. And this includes appropriate computer and file passwords that would be difficult for others to guess. And then looking at the physical setup of your office, whether you have soundproofing, double doors, the use of white noise machines, when you're discussing confidential information with others. And aware of how, where support staff may be, or where you are, like near a waiting room, for example. And so I have had the situation, we move people's desks frequently at our agency. And I've both been in an interior office where I can close a door, and I've been out in a cubicle area that's more in the common area. And there are times when I will go into a closed office and shut the door when I'm talking with a particular community about a confidential issue. When I'm talking with a coordinator about a confidential issue, I will go into, if I'm working at a cubicle, I will go into a private office and shut my door so I can have the conversation in there just to protect. Okay, next one. key terms. This is something that is, I think, really important for folks who are doing research. But it's good for us to know this as well. Personal identification indicator numbers, PII, is defined in the OMB Memoranda M07-1616, which is a federal government document, refers to information that can be used to distinguish or trace an individual's identity, either alone or when combined with other personal information that is linked or linkable to specific individuals. So this is, when we're doing research with folks. So examples of PII include social security number, passport number, driver's license, taxpayer identification number, patient identification number, financial account number, credit card, their street address, email address, personal telephone numbers. So this is not only for people research, but service recipients. Chances are we in traditional prevention programs working with communities are not going to have access to this kind of information. We may have somebody's street address, email address, personal telephone numbers, and we wouldn't share that with other folks. But the other information, chances are we're not going to have that. But if you're serving clients in more of a counseling or a clinical situation, you may have access to that information. Or if they're participating in a research study, you may have access to that information. So that's all considered private information. Okay, thank you, David. Okay, Health Insurance Portability and Accountability Act of 1996, the HIPAA, is a federal law that required the creation of national standards to protect sensitive patient health information from being disclosed with patients without the patient's consent or knowledge. I'm sure you've all when you've been to a healthcare professional, have signed a form that says who they're allowed to release information to, that they're not allowed to release information about you or your health situation unless you designate certain people. And that's basically what this is. And it's to protect patient health information about that. What's your status? If we're talking about HIV, or if we're talking about substance abuse, substance misuse. I'm trying to think of some other sensitive patient information. Do you have an STI? Those are just some of the things that are protected under this. And technically, I don't even think they're supposed to say whether you're receiving health care, I think. And if somebody knows different, feel free to jump in. But so that's to protect us as the patient from healthcare providers sharing information that isn't authorized. And then the FERPA, the Family Education Rights and Privacy Act, is a federal law that gives parents certain protections with regard to their children's education records, such as report cards, transcripts, disciplinary records, contact and family information, class schedules, and other information as well. And so that's, I feel more confident as a parent knowing information about my kids isn't being shared inappropriately with other people, and it's not being shared outside the school as well as people who don't need that information to assist, my son or daughter. Okay. Okay, David, are we going to go through these or are we going to pass on these? What would you like to do, given the time frame?
I think I'd prefer passing on them.
Okay.
So we'll pass
And you
and
can review these dilemmas, if you will, or scenarios when you get the PowerPoint presentation. You can go through those and think about those yourself. The last one is ethical obligations for community and society. And I think this is one we often don't think of as a one of the ethical principles. And basically, what are our obligations to the community and society as a whole? And so we'll look at the next slide. Prevention specialists should be proactive on public policy and legislative issues. Proactive, that means working on behalf and not waiting, for something to happen, but really working actively. Public welfare and the individual's right to services and personal wellness shall guide the efforts of prevention specialists to educate the general public and policymakers. Prevention specialists should adopt a personal and professional stance that promotes health. Okay. And there's three things here, three key ideas. One is advocating for professional, both in our communities, at the state, at the federal level. The second is protecting the health of others and promoting prevention. And then the last one is promoting our own wellness. Alrighty. And when we're looking at advocating for prevention, what we're talking about is advocating for prevention services, prevention programs, just for prevention, as a concept, as an idea itself, at the community level, at the state, and at the federal level. And one example might be a student survey. Perhaps you're in a community that hasn't done a student survey in a long time, or they've never done one. And so advocating for that student survey that's done through the schools, we could talk about the benefits, the information we're going to learn about our students. So not only the community coalition, but other providers in the community can know about the health concerns, the strengths, the risk factors that our young people are facing. So we have a more clear picture, and we can use that as a strategic planning tool. So that's one example. Another example was when kids started vaping in 2018, 2019, a couple of states had created tobacco 21 laws, but most states were doing tobacco 18. Your sale, the legal age of tobacco sale was 18. And what some communities in Connecticut started doing, and we had tried to get a state law to raise it to 21 for several years with no luck. And what some communities did, just like they did with social host, is they started advocating for local ordinances in their communities to change that. And then momentum started building with more and more communities doing that. Passing a local ordinance for tobacco 21, just like with social hosts, local communities, and that built up momentum to help the state pass it, pass both of those. So now we have state laws that tobacco purchase is 21, and we have a social host that you can't serve to minors, alcohol to underage people. The second one would be with marijuana legalization. It may be looking at the zoning or ordinances around where it can be. There's laws in the legislation that says where it can be sold and where it can't be sold, but communities have the right to say, no, we don't want to sell it at all. They have the right to opt out. And also they can put in even stricter restrictions or regulations about where it is sold. And part of that advocacy might also be educating the community around how marijuana affects young people and the need for safe storage and safe disposal, just like we do with opioids. So that's advocating for prevention. Okay, next one. And this is basically protecting the health of others. And, a good example of this was tobacco-free spaces or clean air laws, where, we started restricting the places where people could smoke to protect folks from secondhand smoke. And so it's going to be interesting with the marijuana legislation, talking about where people will be able to use that and protecting others from it. So that's just one example of protecting the health of others and promoting prevention. Another one would be looking at social disparities of health and looking at some of the obstacles that people in underserved populations or marginalized communities face when accessing health or health information, and how do we break down some of those barriers, and how do we work with other folks in the community who are already working on that, supporting their efforts and collaborating with them. And then number 3, and this is promoting our own wellness. And this is, making healthy decisions about ourselves, recognizing that we are role models for the people we work with, and both young adults, youth, families, adults, also providing peer support to folks who may be struggling, and supporting them in their efforts in recovery, in their efforts around intervention, getting access to treatment, supporting folks, and confronting folks who may have issues as well, and getting them help. So basically it's promoting our own wellness, serving as a role model for others. Okay, thank you. So this is ethical obligation to community health and prevention promotion is, we are not only working with the specific community that we've been hired to work with, but we're also looking at this, both in our personal life. For example, I'm a trainer, I'm a member of a volunteer for my local community coalition, I'm a parent. So those are all different levels that I can be advocating for, asking questions, learning more, and advocating for positive health. Okay, thank you.
All right, so hello everyone again. So now we're going to offer you guys a learning checkpoint. You all can test your knowledge by taking the quiz at this link, and it should appear in the chat momentarily, or you could use your phone to scan the QR code on the right to access the quiz. And during this quiz, we'll take like a 15-minute break, and we'll meet at 11:25. Yep. And then after then, we'll go into breakout rooms, and then we'll have like a fun activity for everyone to do, and like that'll be the engaging part. So looking forward to seeing you all.
I just fucking hate it.
Anybody in here?
No.
Thanks for not before.
Welcome. All right, cigarette, glove.